Hi, good afternoon. My name is Matthew Lemak, and I'm the Chief Executive Officer of MEREM Health. Today we're welcoming Norman Tynes from Harbert Realty with us, just to talk through a number of items, and most especially bricks and mortar and clinical development. Norman, with a number of our clients, has been very helpful over the past decade, probably developing close to 250, 300,000 square feet of various medical properties, from outpatient physical therapy clinics, diagnostic centers, the first freestanding emergency department in Alabama for the University of Alabama at Birmingham, to surgery centers for Tenet. So welcome him today to just talk through a couple things and some of the positive trends and negative trends that we're seeing in the market. And at the end of this, Norman will give us some contact information. So if you have any questions or he can be helpful to you, please reach out. You will find no one, from our experience, you will find no one better suited. With that, Norman, tell us kind of a little bit about yourself and background and what you've been doing as of late.
Okay. Well, I've been in commercial real estate for right at 30 years now. I started my career in '87 in Orlando, Florida, and was there for about 5 years, and recruited to Huntsville, Alabama with Harbert in '92, and was there about 10 years before circling back to Birmingham. I've always started my career in development, building office buildings, and really had an interest in medical facilities and medical office buildings, largely because of my father. He practiced medicine at St. Vincent's for 40 years as an infectious disease and internal medicine doctor. And what was unique about his practice, he and his partners owned the building. It's currently now, was located in the parking lot of the emergency department at St. Vincent's. So that building, through the clinic or the practice paying rent to the owner, educated me and my two brothers and sisters. He put it into an education trust. So it was a real estate financial vehicle that my father used to educate his kids, which was creative and pretty cool at the time, something that he set up in the 60s. So with that experience and wherewithal, it led me to focus on medical office buildings. And I think the first deal that I got involved in was an ambulatory surgical center in Gardendale. I was asked by you and your partners to help assemble a piece of property, cost it out, do a complete pro forma, and deliver the project for the ASC operator on time, on budget. And that was a great transaction, and which led to a medical office building right next door. In turn, led to some other medical facilities throughout the metro Birmingham area. And it really was the platform that allowed me to take that skill set and chase other medical development opportunities. Harbert, about 3 years ago, competed for Alabama's first freestanding ER, or FED, freestanding emergency department. We did that for Metro West and UAB at 150 and 459. It was
in Hoover.
In Hoover. 7 competitors, development teams, and our response to the RFP was the most competitive, the most experienced. We ultimately won that business and delivered that project for UAB, and it was a great experience, and we've moved on to some other MOB work for other hospital agencies and practices, and looking for opportunities to redevelop either existing facilities to be medical related or new construction. But new construction has become quite challenging as of late.
Yeah, let's talk about that. Now, I want to hit on one thing. We frequently talk about medical tourism and the capital that's expended. The project that Norman created generated momentum. For those of you not from the Birmingham area and familiar, Hoover is our largest suburb with about 120,000 residents, probably one of our fastest growing suburbs. But the development that they created with the first FED is now 2.5 years later, roughly created momentum for a replacement hospital, the early discussions for replacement hospital, and about a $300 to $400 million project for replacement of UAB Medical West to go adjacent to or almost adjacent to the facility that they created. So it's one of the things we frequently hear about economic generation and development. Well, that's it. They started with a 25,000 square foot FED. Is that fair?
Yeah, 25,000 with a 5,000 foot clinic attached.
Yeah, and it's now looking like it's going to morph itself less than 3 years later into 200,000 to 300,000 square feet of hospital relocation. So with that, kind of interesting. Before we got on, Norman was telling me about a project he's working on. I think one of the first rural projects he worked on in Talladega, Alabama. So 35 miles, 40 miles to our east, with an outpatient physical therapy and urgent care operator attached to it. What's it been like going rural and looking at rural medicine?
Well, to me, it's really kind of an untapped market. What I find interesting is the population, the healthcare population that needs care. They really don't want to go to the large hospitals anymore unless they have to have overnight surgery. So what I'm finding is the clinics and the healthcare providers are going to the people, out in the secondary and tertiary markets and building these smaller clinics so the patients can come to them quicker, easier, less hassle, and get diagnosed, get treated. And if need be, a hospital visit takes place after the fact. So we're seeing a trend where the hospitals and the larger practices are reaching out to the people in these smaller markets. Now when going to Talladega, we had a real hard time finding a good healthcare piece of property that met the needs and requirements of the user. So we did find a good piece of property finally, and it's a rehabilitation property that we're basically going in, keeping the shell and the skin, and gutting the interior, new roof, new mechanical, electrical, plumbing, and really bringing it up to a first-class medical facility. It's sometimes tough to do business in smaller markets. The construction pool of talent is harder to get there. I mean, healthcare construction, you just can't use any contractor. You can't use any subcontractor to produce these spaces in healthcare because they're so technical, and costs are driven up because of some of these rules and guidelines and what the healthcare providers need for these facilities. So you've got to almost import the talent to create these facilities. So it certainly has its challenges going to these smaller markets, but the demand is there.
As you did a project like that, one, rural, two, in general, what's your experience been with lenders being able to understand the operation, and lenders, bankers, being able to understand the operational financials of healthcare, whether it be from accounts receivable to asset-based lending, and those kinds of things? Have you seen that to be a challenge? Have you seen pretty good knowledge in the marketplace? What's been your experience with that?
My experience is dealing with lenders is they have a strong appetite for healthcare real estate. They like to lend in that asset class, and it really boils down to the end user and the term of the lease. And because healthcare real estate is so expensive, and what these clinics are putting in the space with all the equipment and X-ray, depending on what they do, I mean, it costs a lot of money, and depending on how the deal is negotiated, the landlord pays for most of that. So we need a long-term lease to recapture that capital, and finding tenants and healthcare providers to commit to long-term leases is a challenge, because it's a business that's forever changing. But the capital markets are very bullish on the business, and you can find debt for healthcare projects in smaller markets. Now, finding the equity, if you need it.
Yeah, explain to us the equity portion, what you're seeing that. So in equity, we're talking more of a down payment. What the cost is to enter, or what is needed up front is a early commitment and mitigation of risk for the lenders. So we're seeing anywhere from 15 to 25% equity requirement.
Yeah, and I think the 15 days are over. I think it's more 20-25%. It all depends on how the deal underwrites. And margins are getting thinner, yields are being compressed, because the physicians and the practices have got to control their occupancy costs. So they're really pushing down the rents to make the deals work for themselves. So the investors and the developers of healthcare real estate are starting to have to accept smaller margins to get the deal done, because it costs so much to produce these facilities. So the equity players who want to invest in real estate are seeing their returns compressed, a little bit, and getting them to go to third tier market with weaker demographics was a challenge of mine, but we overcame it.
And by third tier market, you mean tertiary, more rural, more than 50 miles outside of MSA?
Absolutely. Yeah.
What else have you experienced? I mean, and I'm going to give you a hypothetical scenario, which I know you hate, but if you had, from a lead time perspective, we have a lot of clients frequently ask us, we have a lease burning off in 6 months. We want to go build our own building or do something different, or we're 9 months away. What is the ideal time frame? And let's just assume we're talking about a multi-specialty clinic, 7,000 to 10,000 square feet, 10 physicians. How much lead time do people really need to give themselves to design, price, and get relocated, and build and get relocated into a building? What's the ideal amount of time?
Well, it takes a year to build it.
Okay.
So there's 12 months, and sometimes it takes a year to identify an acceptable site, control the site, sort out all the entitlement problems, issues, title, geometry. Who knows? It may be a rezoning case. It just really all depends. So ideally, I'd like 2 years, 24 months from engagement to delivery. And depending on the size of the project and the location, it could be even more.
So I think the word of the wise on the folks that ask us that question is don't wait until you're in the last year of your lease to start making plans.
Oh, no way. And especially if you want a new facility and to make it more efficient, there's a significant amount of planning that goes into these facilities. And quite honestly, getting the clinics to focus on that is also a challenge, because the people that know how they want their clinic to lay out are so busy seeing patients, it's hard for them to find the time to focus on something that may take place 2 years from now. So having a single point of contact who knows the ins and outs of the clinic and the operation of the practice and how to make the space fluid and productive, and being able to focus on it, make decisions quickly, and the more work you put in on the front end of the project, the better it will be at the end of the day.
So from your experience and going through this, I'm going to say on 15 projects now, roughly?
Oh yeah.
If not more.
Well, and that doesn't count the ones that we chase and never materialize.
Sure.
Which we do a lot of that.
Is the biggest challenge always, if you could identify the biggest challenge, and I know each project has its own unique set of circumstances, but is it truly getting in the design phase to be able to get to a pricing set? Where or is it in the financing phase of it? Where do you really see the biggest challenge from the operators that hinder that timeline, that delivery timeline?
Well, I think every business has an expectation on what it should cost to operate from a real estate standpoint. And if that's going into an existing building with some little modifications of TI, that's certainly one price point. But new construction is, in today's world, is another price point. So being able to say with certainty what those costs are going to be projected 24 months out, you have to know what you're going to build today and put an escalator on, because construction costs are rising
very rapidly.
I mean, almost where it's really hard to peg, and you're giving them a range of rent. But if you know exactly what you're building early and are willing to spend the architectural and engineering and design dollars to fully understand that and get it priced by a competent healthcare contractor, then you have less surprises on the back end. I find that the healthcare practitioners don't like to make that investment on the front end to understand for certain what their future occupancy costs will be. They place that burden on firms like mine to do that for them, which we're prepared to do, provided we don't go spend, significant A&E money and the project gets scrapped, and we're left with all these costs. I mean, there's a cost sharing agreement going into something like this.
Sure. So we got an email question earlier today, and again, a generic question that I know is always hard to answer. But the question was, is it easier to go into a renovated shell base building or easier to go ground up? And is it any faster? I have an opinion on this from some experience, but I'd love to hear yours.
Well, I think it depends on the practice. I mean, if it's an orthopedic practice and you're heavy in scans, X-ray, and MRI, I think new construction is the way to go. It also depends on the integrity of the current structure and code and location and sometimes going into a rehab, it's like fixing up an antique car. At the end of the day, you're going to have a lot more money in it than you would if you went and bought new. So it all depends on the circumstances in the building that you want to remodel. I think healthcare wants new, clean, crisp architecture and a pleasant patient experience, and I'm seeing more demand for new vertical construction than I am rehab.
That's fair. I think that's what we're seeing in the market as well. Recently, we are in the midst of working on a project together, and I would tell you, and it's in the Central Alabama market, we are experiencing about equal cost on a renovation versus ground up is what we're experiencing right now. So that, Norm, would you mind sharing some information if folks want to reach out to you directly?
Yeah.
And great resource. Again, we have a lot of experience together, but please feel free to reach out to the expert.
Norman Tynes. I'm with Harbert Realty Services here in Birmingham. Phone number 205-458-8105. And my email address is ntynes, Tynes, @harbertrealty.com.
Sure. So for all of us at MEREM Health, thanks for tuning in to this Facebook Live session on Thursday. Briefly, before we get to the holiday, next Tuesday we'll be having Tip Tuesday before the Independence Day holiday. Happy 4th, and hope you enjoy the rest of your day. Thanks so much.
Thank you.